Hi, my name is Jeremy Ann, and thank you for this opportunity to present this case of an unlikely diagnosis, the third element in a case of altered mental status. Our patient is a 55-year-old female with history of depression and multiple suicide attempts, who was brought into the ED by her brother for possible overdose on a substance. On initial presentation, the patient was calm, able to participate in the interview, and had a fairly normal neuro exam. She denies ingesting any substances, but she was just discharged 2 days prior from the psych service without any new medications after a TCA overdose. Her labs was only notable for a creatinine of 1.2 from her baseline of zero point 0.7. She was medically cleared but was admitted to psych service for observation. For several hours later, she was found to be confused, so she was transferred to the internal medicine service for management of altered mental status. Her physical exam was notable for being oriented only to herself, and she was unable to follow even simple commands. Her muscle tone was normal, but she was diffusely hyperreflexic without clonus, and she also had an ataxic gait. Her lapse at this time was significant for an uptrending creatinine of 1.44. Her symptoms persisted for 72 hours from initial presentation. Medication reconciliation was performed, which included an antipsychotic, antidepressants, and benzos. Given the medication list, some of the things on our differential at the time included neuroleptic malignant syndrome and serotonin syndrome, and the clinical findings are listed here. Poison control was consulted at the time, but they weren't really convinced that the patient's presentation is consistent with any of these syndromes. Given her persistent altered mentation, slow clinical improvement, and negative medical workup, her lithium level was checked on hospital day 3 and found to be 2.3. Normal is zero point 0.5 to 1.5. So you can see that her levels are still markedly elevated even after 72 hours. We also found out that she was prescribed lithium several years ago by an outside provider. The patient was then managed with IV fluids to assist with renal clearance of lithium, and 2 days later, the patient's confusion resolved and her mental status returned to baseline, although she continued to have a slowly improving ataxic gait. Lithium carbonate continues to be recommended as a first-line mood stabilizer for bipolar disorders. However, it has a narrow therapeutic index of zero point 0.8 to 1.2, and toxicity can present with nonspecific symptoms such as diarrhea, weakness, confusion, and somnolence. The toxic dose of lithium is not well defined. That are reported after ingestion of just a handful of pills, while other patients have survived large ingestions up to 84 grams. The serum half-life varies from 12 to 27 hours, and with chronic intoxication, half-life can be prolonged up to 48 hours. Versus with NMS, the symptoms typically evolves within 24 hours, and serotonin syndrome is even much faster, typically within 6 to 8 hours. The clinical findings in lithium toxicity can be categorized by systems. You can have nausea, vomiting, diarrhea. In the heart, it can manifest as prolonged QTC and bradycardia. You can also have AKI and nephrogenic diabetes insipidus. And lastly, neurologic findings develop late in acute poisoning because time is required for drug to penetrate the CNS. And the symptoms include ataxia, confusion, and neuromuscular excitability. When lithium toxicity leads to long-term sequelae, the syndrome is called SILENT, which stands for the Syndrome of Irreversible Lithium Effectuated Neurotoxicity, which mostly affects the cerebellum and brainstem. And it is proposed that demyelination caused by lithium at multiple sites in the nervous system is responsible for the persistent deficits. So, in summary, this case illustrates the challenge of diagnosing acute lithium toxicity in the absence of having clinical history from the patient and family. At toxic levels, lithium affects the renal and CNS systems and can have long term sequelae on both systems. The neurologic symptoms of lithium toxicity often present late, up to 40 hours of ingestion, as the drug requires more time to penetrate the CNS. And finally, lithium is cleared by the kidneys, but is also nephrotoxic, leading to impaired clearance and prolonged symptoms of overdose. Thank you for your attention.